So again, a very good evening to everyone. So this course is on recent advances in refractive surgery, and of course, a lot has happened. Refractive surgery is ever evolving, where something new comes up every year. Few new techniques come up every year, and there's been a lot of advancement also in the investigative modalities. So Dr. Chitra gave me this topic to speak on. So if we look at how refractive surgery investigative modalities have evolved, you will see that in the 1880s, a proper Placido disc was used, and they would look through it from the central hole and with concentric rings to see the regularity of the cornea. And then that evolved into the photokeratoscopy, where a photography technique was added to it. That was in the 1950s. And we started measuring the cornea's curvatures only in the 1960s with the keratometries of the corneal measurements. And in the 1980s and 90s, we came up with the topography systems, which is what we use today. And of course, after that, in the 90s, we got the Scheimpflug imaging, which was one step higher because it could image not only the front part of the cornea, but also the posterior corneal measurements. In the 2000s, we also started doing anti-segment OCTs. I remember when Visante was launched, and we suddenly could see OCT profiles of the cornea. It went on to evolve, and then the iTrace came up with diagnostic aberrometries of the cornea. That was in 2001. In 2010, they started doing biomechanical imaging of the cornea with the Corvus system, which came up. Recently, we started using in our clinic also the Anterion high resolution swept source OCT, which was launched in 2021. It's an amazing piece of technology that does great epithelium mapping, and also corneal maps are amazing, and it can also do all the curvature maps and the pachymetry profile maps, and it has an Ectasia score. In 2023, they further went ahead. MS39 has been around for a couple of years, which combines corneal topography and OCT based imaging into one, and it has a very high resolution swept source OCT. So I'll start by talking about a few of these devices. I started using the iTrace about 4 or 5 years back. It's an amazing piece of equipment. Basically, it's an aberrometer, so it has ray tracing wavefront aberrometry, and that is combined with corneal topography. So you can see that this is the topographer cup over here, and of course it also has ray tracing aberrometry combined in it. So it's an amazing device because what it can do is, while taking both the measurements, it can then try to identify and separate out the internal aberrations from the corneal aberrations. So what it will do is, it will take all the aberrations of the eye and also measure separately from the topographer the corneal aberrations, and then it can subtract the corneal aberrations from the total aberrations and tell you what are the internal aberrations. So that can tell you what is basically on the crystalline lens. So that helps you a lot in understanding where the origin of these aberrations are. So it helps you a lot with planning for refractive surgery, just like a normal topographer would, but it also gives you angle kappa and angle alpha, and it also gives you lenticular aberrations and the higher order aberrations, besides giving you the corneal aberrations. So the key features, as I told you, are corneal topography, wavefront aberrometry, and it has a ray tracing feature which can tracks the path of light rays through the eye to measure the total refractive power. So it will give you a eye trace refraction. So it gives you an aberrometer assisted refraction, which is again pretty accurate. The clinical applications could be in understanding all the aberrations of the eye for refractive surgery patients. It also measures visual function, and it can give you the PSF analysis, then the Snellen e-simulation analysis. So it tends to help you in diagnosing how the visual quality of the patient. And also you can study the changes in the accommodation up to 4 diopters, and it does a good visual acuity analysis. It has a corner screening software. It also helps understand the contrast sensitivity and helps in deciding which premium IOLs you can use. So it's a very nice device. It does have its limitations. If you have a dry eye, or if you have cornea is not very clear, or if it's in the presence of cataract, the aberrations will go haywire. So it does have some limitations, but by itself it can give you a lot of help in a refractive cataract practice. It also helps you with toric IOL planning, and it can give you toric check basically to see whether your toric is aligned correctly or not, and then it also suggests how much you can rotate to realign it. So just to show you an example, this was a patient who came to us, had 16.75 sphere in the right eye with a small cylinder, improving only to 618. In the fellow eye, which was the good eye, the power was just about -5, with a small cylinder improving to 6.6.
Excuse me.
So the right eye had been labeled as anisometropic amblyopia, and the left eye was obviously having just a regular myopic astigmatism. When we did the pentacam, we saw that the corneal thickness was fine, the curvature maps were fine. There were small suspicious areas on the Bellin's map in the right eye, and left eye seemed mostly clear. When we did the eye trace, which I just spoke about, the right eye showed significant aberrations on the internal aberrations. Basically, the total eye also had a lot of aberrations, but you can see that the cornea is very good. All the aberrations are on the crystalline lens, so the dysfunctional lens index is just about 1.6. And if you separate out the aberrations, so these are the total aberrations, and you'll see a lot of aberrations. These are the corneal aberrations, which you can see are negligible. There's almost, the cornea is very pristine, and all the aberrations are in the crystalline lens, even though it's a clear lens. This is a young patient. There is no cataract at all, and optically it looks absolutely clear, but the lens has all the aberrations. Now compare it to the fellow eye. Fellow eye looks much better with the one which is -5, and if you separate out the aberrations, there are almost no aberrations on the lens nor on the cornea. So it immediately tells you, while the left eye is very nice optically, the right eye has very poor optical function, mostly because the crystalline lens is having all the aberrations. The cornea seems good. So what should we do for this patient? Kumar, if you are hearing and watching out, what should we do for this patient, for the right eye and the left eye?
No, what was the...
So I'll quickly take you back. -16 in the right eye, -5 in the left.
The quality of vision could have been subnormal. He could have been amblyop in that eye.
Exactly,
also.
but look at the aberrations. These are the aberrations of the right eye.
Was it a Indian phakic IOL or?
No, there's no phakic IOL. This is just a refractive surgery candidate.
Oh, okay.
Yeah. So one eye has almost no aberrations. The right eye has so many internal aberrations and none on the cornea. The other eye has no aberrations at all. So obviously the left eye, I'm going to go ahead and do a smile or something for that. What should we do for the right eye? Should we go ahead put an ICL? There's enough AC depth.
Yes.
Or looking at these maps, you want to offer something else?
See, what is the index?
The DLI? Okay. So the DLI is 1.6.
So theoretically, you're supposed to treat the lens.
Optically, the lens is absolutely clear. There's no cataract.
So then something's wrong with the DLI.
Yeah. So it's basically an aberrated crystalline lens.
Yes.
Too many aberrations, right? So
it could be. It was no lenticonus or nothing at all like that.
No lenticonus, nothing. Sorry. Right. So that's what I was coming to. This becomes a very useful tool to decide whether it's a lens. Now, suppose the same patient had no aberrations on the lens. Then we knew it was amblyopia and nothing else. But here it's so clear that the aberrations are all from the crystalline lens. So we went ahead with a dysfunctional lens exchange.
Oh, very good.
And following the procedure, patient's DLI obviously improved to 9.58. Patient also got a plano outcome with a 6.9 kind of a vision in that eye. And fellow eye, of course, we went through with a smile, and you can see the DLI in the smile eye is actually worse than the pseudophakic eye. Yes. So patient very happy with both eyes outcomes, and that was one representative case. We also use a lot on the anterior, which, as I said, is an anterior segment swept source OCT, which also doubles up as a biometer, and it has excellent depth of penetration. It can give you scans from the cornea to the posterior capsule in one picture, along with the limbus and beyond. And it is, I will not go into the detailed features, but it does a great job of not only a deep, capture, but also a wide capture of almost 16 millimeters and a depth of almost something like 12 millimeters. So it gives you everything in one go. And it does a great job with the biometry. It also has ray tracing, and so it can do ray tracing biometry measurements as well. So corneal disease, it gives you the cornea module, which helps diagnose epithelium maps, also the maps which are basically from the stromal thickness maps and the ectasia scoring software. The glaucoma module, which gives you the angle studies and measurements, which are pretty good now. The refractive surgery module, which gives you all the cornea curvature maps as well. And as you compare it to the pentacam, you can see that it stands out as giving much more information. But pentacam has been around for long years, and we still trust the pentacam for many of the softwares that it comes with. But the OCTs, all the anterior segment OCTs are coming of age, and they are gradually probably the future. Even pentacam has launched an OCT-based, refractive measurement module. So I won't go into the detail, but if you look at the corneal maps from the anterior on the right side and from the pentacam, you will see that they stand out as pretty much comparable. And so we do use the anterior now for much of our refractive surgery evaluations. This is the fellow eye, and again you'll see that they come out quite comparable. Epithelium maps are done in a 7 to 8 millimeter zone, and they come out good as well because they can be used to subtract for the for giving you the stromal thickness maps as well. So these are the epithelium thickness maps for one of the patients that I can see over here. This is a score analyzer, and the ectasia score can be seen here on a index over here, and if it's in the range of maximum up to a +1, 1.5, it's good. Beyond that, it starts going into the red. I think another application for the anterior for us has been phakic lens planning. I'll finish with this because I've run out of time, so I'll just finish with this. The anterior and the other the OCTs like the MS39 and the Cassia, they can all be used for very good phakic lens vault planning and sizing, because they are able to give you very good measurements of the scleral spur to scleral spur or to the angle, as well as also the crystalline lens rise and the lens vault and the AC depth very nicely. So these measurements can all be used for various of the new formulas like the lasso techniques, where you can do very good ICL sizing planning and vault predictions. So we have been using the Anterion for this purpose as well, and it has come out pretty good. So we've gone on from white to white and AC depth measurements for ICL measurements, ICL sizing to ICL sizing on the Anterion, and these are all the measurements that I mentioned that you can do on that. And this is how it looks. So your yellow line is signifying the scleral spur to scleral spur, angle to angle, and these are the vaults, the lens crystalline lens rise and the lens vault. So I think this was one of the KIMS software, which KIMS nomogram, which can be used for sizing, and we've been using this for our purposes and found that this works out much better than the manufacturer's nomograms. So we use this in addition to that. So with that, I think I'll stop because there are so many other speakers, and I'll invite Dr. Chitra to invite.
Please join us back on the ties. Don't be a busy man. Will you take a question?
So, Gaurav, to you, you have the eye trace for many years and this dysfunctional lens index. If you would have done clear lens extraction or something like this, how much does it protect you in legality? Because that's the only machine that gives you this. So will it protect you in legality, or it doesn't protect you in legality?
Also, sir, the outcome itself can vary significantly based on how well the tracy refraction. It's a ray tracing refraction, and a lot of aberrations can arise if the refraction itself is not on point. And a high myopic eye like that, for us to be 100% sure that the refraction was perfect, and whatever we are seeing is only because of aberrations, is very difficult to say, because like you said, we don't have comparative devices to measure it. Like we can measure white to white ACD with so many devices, and we know that one overestimates, one underestimates. So yes, I do believe that at least I won't go only by DLI as a single measure as far as decision making goes. And obviously that patient is amblyopic and doesn't have the same quality of vision as they would in this eye. And I don't think it would have been wrong even if we did a phakic IOL in that eye instead of doing a clear lens extraction in a high myope.
Yeah, that's for other reasons, more than the high myope which is coming in the way, because of the view of the myope, the retinal condition.
Absolutely.
It's not working.
So maybe we have time for one more question, since Gaurav sir is also there in the hall.
Yes.
Sir, if you can take one question just on AIOS2025 epithelial thickness. I mean, we are seeing very often that there's a lot of changes in the epithelial thickness map, especially after refractive surgery, and serially we do these maps, we see continued change. So while we do attribute a lot of regression to the epithelial thickness itself, how does it change your decision making as far as the treatment outcomes are concerned, or treatment planning is concerned?
Right. So post-op, we monitor epithelium thickness maps for most of our refractive surgery patients, and we found a big difference in many of them. For example, between SMILE and SMILE Extra, there's a clear difference between epithelium remodeling. In PRKs, between trans-PRK and PRK, there's a difference in how the epithelium thickness, evolves over the next 3 to 6 months. And there will always be outliers. You will notice some of your PRK patients who are not doing well, and they keep coming back even 3 to 4 weeks or 6 weeks after surgery, and you wonder why they are not seeing well. And if you just do the epithelium maps, you'll realize some of them are lagging in that epithelium healing. They'll still be having like a 40 micron epithelium, which is not regular. There will be some astigmatism, and you'll see that astigmatism on the MS39 epithelium maps, which is clearly showing that astigmatism because of that, line of fusion where the epithelium is closed. So I think today, more than the post-operative patients, more than the pentacam or something, I actually see the epithelium maps much more. And you see them over 6 months or a year, and that evolution happens, and then eventually some of them will get epithelial hyperplasia, and then you can quickly see that why there was a regression. Others will have delayed epithelium healing responses. So I think it's a learning experience, and I'm learning over the last few years that I'm doing these epithelium monitorings.
Wonderful, sir. And yeah, Rizwan, ready?
Gaurav, all the epithelium maps that we are seeing is central 6 millimeter. Am I right?
So the thing is, Anterion gives only about 6 to 7 millimeters, but I also use the OptoView for more than 10 years. That gives me 9 mm maps. Frankly, for example, like hyperopic ablations or large optical zone laser correction treatments, we see the maps much better on a 9 millimeter. The MS39 gives you 9 millimeter maps. Anterion is lagging in that, and I think even the Anterion's epithelium maps resolution is not, it's kind of has too many artifacts. But even that old OptoView with the 9 mm gives you a lot of information.
Again, one small challenge is that just like we spoke about the DLI, the epithelial thickness mapping and the pattern and the landmarks, how it identifies, is a little different from each of these devices. The OCT-based devices versus the ones which also combine Scheimpflug. I think what we get in Anterion versus what we get with the OptoView is the epithelial thickness is not as...
The thickness is off by 4 microns for every patient. So, when you're doing a planning for transepithelial, the OptoView will tell you to ablate 55 microns, and Anterion will be telling you 50 or 51, so then you don't know which one to choose.
Can you connect, please? I think I'll start my talk. You'll all have trouble. A very good afternoon to one and all of you, and my special thanks to my moderators on dais. I'll be first taking you on to corneal surface ablation, and we'll definitely ensure there are adequate discussions which follow each of these talks. So we knew that surface ablation has been there for over 2-3 decades, but it has got rejuvenated now because we better understand the biomechanics. What we all very clearly understand is that the anterior stromal fibers have a lot of significant cohesive tensile strength in the cornea compared to the posterior fibers. And again, the peripheral fibers are stronger than the central fibers, and this has to be kept in our minds. And this has been further substantiated by the electron microscopic and the Brillion microscopic study. So basically, when we talk of surface ablation, we are meaning the PRK, which was earlier the conventional one, then the transepithelial one, then the topo-guided PRK, then the PRK extra, then came the PTK, and of course, topo-guided PRK with CXL and TREC for keratoconus patient. Now, why the conventional PRK of manual debridement or using a rotating brush is not that good enough is because the epithelium removal is not uniform. So there could be an asymmetric hydration, and also an inaccurate ablation pattern can occur as against a laser transepithelial PTK and PRK being either done in a single sitting at one go, or PTK followed by PRK. Whichever way it is done, there is less time consumption, there's less hydration of the stroma, and the ablation pattern is more uniform. We all know surface ablations are largely done for thinner corneas, but again, a normal keratometric reading. But it has a special role where there's an epithelial basement membrane dystrophy, or any kind of anterior segment stromal dystrophy, or recurrent corneal erosions. But although we prefer to do only up to 6 diopters of surface ablation power correction, there are a few who do a higher correction. And herein what they do is they use mitomycin for a longer duration. And hyperopic class PRK is not very effective, and it is infrequently done because the regression is more because of the curvature change which occurs and the epithelial hyperplasia which can occur in these hyperopic eyes. Again, those patients who are not eligible for SMILE or LASIK procedures, and if they have enough stromal bed, residual stromal bed of 300 microns, we could do a surface ablation. It can also be done as a surface enhancement procedure post PK, RK, LASIK, and SMILE. And when we would not do a PRK is if it is a very low myopia of -1 or less, because there is some amount of epithelial remodeling which is suddenly sometimes can be fallacious, and we may not get that bang on correction. And if there are certain systemic autoimmune diseases or an ocular inflammation or a history of herpes or any viral infection, we would not do it. And again, we would not do it if the corneal thickness is too low or there are deep stromal scars, vascularization, corneal aesthesia, or steroid responders. So we would do a regular evaluation in corneal surface ablation. We would do an epithelial map. I'm not showing you the procedure, but what we need to know is after we remove the epithelium and do the power correction, when we place mitomycin C, the role of mitomycin C in every single case is it kills the keratocytes and also prevents haze coming in from the migratory keratocytes from the limbus. And largely we use 0.02% for 30 seconds. And there are people who use 10 seconds for each diopter, 10 seconds exposure for every diopter of correction. Then came the PRK contoura, wherein based on a topo-guided measurements which are done, PRK contoura is being done, and it's a highly customized procedure, seems to be in greater accuracy because the maps are done on the cornea and most of the aberrations are on the cornea. And in a topo-guided treatment, what we know is it's a combination of a myopic and a hyperopic correction, which is, and it makes sense. And with the contoura, it is also centered on the visual axis, and there's also pupil centroid compensation. So if you're looking at PRK contoura procedure, basically what is important for us in our selection is the map, ablation profile map of the wavefront guided should be similar to that of the topo guided map we are generating. So we should take initially number of maps, see whether, and compare the maps. Now here, for this power correction of 2.75, this is the ablation map which you see here. And for the small amount of higher order aberration correction, it is 6 micron. But then, this is the final topographic contoura map, but we should compare it with the wavefront optimized map to see whether they are similar. If it is very dissimilar, it could be that there are more higher order aberrations on the eye, and correcting them might induce a refractive error. Again, we know that there are certain borderline corneas of patients with pregnancy or allergic manifestations or a suspicious posterior float, etc., wherein you feel that it makes sense to do a PRK extra like classic extra or smile extra. Essentially, we all know that by doing a cross-linking, what we are actually doing is we are tightening the lamella and strengthening it, and there is flattening of the K. But what is critical is when you're doing cross-linking in a refractive procedure, we do not want a refractive impact to occur. So then what was done with innumerable studies were done, and they decided that using a fluence of 2.7 joules, that is half that of a regular keratoconus patient, and at 30 milliwatts per centimeter square for 90 seconds. 90 seconds exposure to riboflavin and 90 seconds of treatment to ensure that the total energy is 2.7. But there were a few who used different energies and still promised to get good results. What we understand is, if it is in a femto-LASIK extra, there are vertical cuts which are created. In SMILE, a delamination cut is created. This could have a small biomechanical weakening as against surface ablation being combined with cross-linking, which seems to make more sense. It also seemed to make us realize that even those eyes where you're trying higher power correction, wherein there could be more epithelial hyperplasia, doing an extra procedure would tighten the lamellae, give increased rigidity to these eyes. So different studies did tell us that doing an extra procedure makes sense. There's no loss of BCVA. Probably we have to look at it as a prophylactic procedure rather than a therapeutic procedure. And we did a study of about similar number of eyes of PRK against PRK extra for some borderline topographies. But what we found was both PRK and PRK extra, there was stability in the manifest refraction, stability in the K. So then, the other role of surface ablation comes in bioptics. When you do a cataract surgery and a person has a premium IOL implanted and has a small residual error, surface ablation could be an option to go. Again, I'm not showing you the procedure, it's just the regular way it's done. PTK is another mode of surface ablation where you treat anterior corneal pathologies. We can remove only about 100 micron of the tissue, and that is, we should ensure that at least 250 micron of the residual bed is there. We need to do a pre-op OCT, And the indications of PTK are right from corneal degeneration to dystrophy, to recurrent corneal erosion, superficial scars, and old keratitis. This was a case of spheroid degeneration, wherein we did a surface ablation and the cornea stabilized. Sometimes it could be even treated for post-classic macro folds or decentered ablations. It has a role. But PTK cannot be done for deep stromal scars, which are vascularized scars, or if the patient has a diabetes or autoimmune disease, or if there is an earlier history of viral infection in the cornea. We also need to understand in PTK there could be a recurrence of the primary disease pathology like reactivation of herpes simplex virus. There could be a delayed healing of the epithelium and an allograft transplant rejection, etc. And most importantly, sometimes it could induce a refractive error. So it makes sense to even combine it with some amount of refractive correction. The other area where we can do surface ablation is in an early mild to moderate keratoconus. If the patient has a larger coma, a poorer visual quality, and is not comfortable with contact lenses, we need to take on corneas which are at least 450 micron thickness. And the advantage of combining a topo-guided surface ablation regularization with cross-linking at the same time is you are saving the time for the patient, and there's a reduced haze formation because the cross-linking will kill the keratocytes, and because we are disrupting the Bowman's membrane, there's greater penetration of riboflavin. However, when you're treating a keratoconus eye, you can bring the optic zone from 6 to 5.5 millimeter to get a better correction. So you need to check the best 5 maps, and once you have done that, enter the refractive errors. You need to change the whole refractive correction to 0 to understand what is the amount of tissue which is going to be taken away, because we are very specific that we do not remove more than 50 to 80 micron of the tissue. And then this is the kind of map which you get generated here, a myopic with a hyperopic ablation. And you also need to, this is another patient wherein he had a 6 diopter of keratoconus, and we looked at correcting just about 3.75. The anterior float of the treated eye, of the eye to be treated, should correspond with the anterior float of the keratoconus. And see, the patient had a 3 counting fingers. It came to 660 with significant symmetry of the cornea. Like this is a case of a centered cone which did very well, a decentered cone which did very well. So this gives us an idea that you could treat different kinds of ectasia, like in a post-LASIK ectasia here, which had a -2 diopter cinema. Look at the irregularity on the topography, flat superiorly and steep centrally. And this is the kind of improvement from 624, the vision improved to an uncorrected 612 and a BCV of 6.6. I'm not going to talk to you about TREC because this is essentially for corneas which are thinner than 450, and in a Schwinn platform, you are able to treat these eyes. I'm not going to go into the details because I would be overrunning the time. But see, this patient had 5 diopter of cylinder, and we are able to regularize it and bring a 0 correction. This is something which you cannot promise all patients. But suffice it to say that surface ablation as it stands today definitely gives us not only ability to correct thinner corneas, but also abnormal corneas. There are a few post-op challenges which are beyond the duration of this talk, but surface ablation with the detailed understanding of the healing process and the choice of the candidates definitely stretches our ability to treat refractive patients, surgery patients, on a wider range of corrections. Thank you very much.
Thank you very much, Dr. Ramamursi. May I have a comment?
Yes.
Thank you again for highlighting the surface ablation, because I have a belief that we are back again to the surface because of the modern refractive era that we're having in hands now with the good diagnostic tools. And now I'd like to know your experience between matching the topo-guided ablation, which is Contura, and the wavefront-guided ablation, especially that you have both technologies, as I see.
Yeah.
The topo-guided ablation, which is Contura in the, let us say, virgin corneas, is so difficult to calculate. Am I right or wrong in this? It needs a kind of astronomic vision or astronomic calculation, while the wavefront is just with a click of a button, you go ahead. Tell me your intuition about that.
We have found it, a PRK Contura, to be making a lot of sense when you're treating higher cylinders. In a routine topography, it is fine. When you're having a higher astigmatism, it definitely seems to make great sense because you're able to map innumerable points on the topography, and gives greater precision of correction. So
Yeah.
it could be to some extent pushed by the company.
Yeah, and now we have the new trend, which is the ray tracing guided ablation,
Yeah.
which are looking all for. I will acquire this in few weeks from now,
Yes.
and I'm looking for the answer of many things that we hadn't answered before, like the epithelial maps and the effect of the epithelium on the as an epithelial lens on the ectatic corneas and the regular corneas.
Yes, thank you. We'll go on to our next speaker, Dr. Ramurthy, who's going to be talking to us on phakic IOLs. Like, what are these important tips which we need to keep in mind when we are doing phakic IOL in a normal eye as against an abnormal eye, and how you would manage some of those challenging moments. Thank you.
A very good afternoon. I'll be covering on phakic IOLs, the ideal approach in normal and abnormal eyes. It will be largely a video-based course, and phakic IOL implantation, most of you must have done this, and loading of, especially if you talk about the ICLs, the loading of the lens is the most important thing that you need to learn. And this is just the lens which is dispensed in nowadays in balanced salt solution. So there is no enlargement of the lens. It's taken out of the small bottle of water in which it comes and then placed in the cartridge. And after the placement, we are using a front-loading forceps to gently draw it forward. Actually, you pull the cartridge back and the lens should come forward and almost brought to the edge and left there. And this is a couple of modifications that I've been doing for the last 2-3 years. In the sense, I do not dilate my pupils before the surgery, simply because all of us have, with years of experience in phacoemulsification, very rarely while making the incision, there is a sudden touch of the anterior capsule. It's no big deal because you can include it in the capsular excess, but in a phakic IOL, fortunately it has never happened to me, but just in case it happens, that will be the end of the case because the lens would be damaged. So I like to have the pupillary iris cover on the lens, and then this is just the incisions being 1 millimeter incisions being done at the 3 o'clock and 9 o'clock meridian. I am seated temporally. That's a little bit of saline being injected. This is a 3 millimeter incision being made. I always make a 3 millimeter incision because I don't want a wound assisted implantation. Subsequently, this is a phenylephrine and a xylocaine mixture that's injected. And usually in these young myopes, the pupils dilate very well. And what I'm using now is a cohesive viscoelastic, and you can see an excellent dilatation that is there. This is the lens being implanted, and it's important that you ensure that the leading right optic has the small hole over there. And in case you're using the Indian lenses, the indicators are a little different. We'll come to that. And these are the lenses being positioned. And this is the only step that you need to learn differently from what you do in other anterior segment surgery, where you have to gently tuck the lens from behind. And as I'm just hydrating the wounds, you can see the viscoelastic, which is a cohesive viscoelastic, completely flowing out. Once clear fluid starts coming out, I know the viscoelastic is completely drained. There have been questions as to whether there could be viscoelastic captured behind the optic of the lens. But in about 3 years that I've been doing this routinely, this works very well for me. And whenever there's a toric intraocular lens, which is almost 75% of my cases, then there's a Varion overlay that's used. It's hardly an edited video, and as you can see, it just takes about a minute and a half for me to complete the case. And if bilateral implantation needed, we go on to the next eye with a completely different set of instruments with the a separate nurse coming in, and I also change my gloves and my apron before starting the next surgery. And just in case many of these young patients have astigmatism with the rule, and in case it's a small astigmatism of about 0.575 diopters or less, then I even go ahead and shift from the temporal aspect to the superior aspect. And since I make a 3 millimeter incision, I find that this gives me a compensation, especially when it is made superiorly, almost about 0.5 to 0.75 diopters of compensation you get. So you can even implant a spherical lens. Even though the incision is made superiorly, Basically, I'll dial the lens so that it's in the horizontal white to white, because that's how you have taken the measurement. So this is a little bit of a cost saving as far as the patient is concerned, and seems to address low amounts of astigmatism quite adequately without resorting to toric lenses. Though it's important that whenever you have significant myopia, hyperopia with toricity, you have to deal with it completely, because even small amount of cylinder left behind leads to dissatisfaction in the patient. As far as the toric phakic intraocular lens rotation is concerned, you can see the Varion overlay here, and this is the toric markings on the lens, and this is a Indian toric lens, and which also we quite commonly use. And as you can see over here, the alignment is not really perfect. The time you realign these lenses is whenever the residual spherical equivalent is almost zero, because when you are placing these lenses, realigning these lenses, you're not introducing any power or taking any power, but redistributing the power. So if it is -1 with +2 diopters of cylinder, then this rotation is going to help. But if it's just -2 diopters of cylinder, it's a basic error in the calculation of the lens, and the lens replacement may be what is necessary. And I do not introduce any viscoelastic, just go in with the irrigation cannula and with the digital overlay. Of course, you can do it with the manual marking also. I just go ahead and rotate the lens to its new position. And just in case you have the residual refractive error and the new position of the lens and the shift by which it has happened, instead of just putting back the lens in position, and in case you feel that lens is almost in position, still there is residual error where the spherical equivalent is almost zero, you can refer back to the company and they'll get back to you information about how many degrees that lens has to be rotated. And coming on to the less than ideal situations where we use phakic intraocular lens, something like an iatrogenic keratoectasia. As you can see here, it's a well-centered cone, and basically the patient underwent a smile procedure. Surprisingly, 5 years later in one eye developed a iatrogenic keratoectasia, and you can see the significant spherical and cylindrical error that the patient has. We did an intact procedure with CXL on him, and then subsequently the cornea got regularized, and the best corrected visual acuity was 6.9. We go ahead and use these phakic intraocular lenses. Nowadays, it's not a this is an approved indication for using phakic intraocular lenses. Only if the best corrected visual acuity is 6.9 or better, and more importantly, if the cones are centered, in the sense that more than 50% of the cone in the posterior float is in the central area. There have been situations where the cone is slightly decentered, but even if the visual acuity, best corrected visual acuity is 6.9 or better, that would also be an indication for using these toric lenses. That's just that case with a inferior intracorneal ring segment, where we are introducing a toric intraocular lenses to take care of the residual cylinder. So essentially, this is a 3-step procedure where the first and second step are done together. Collagen cross-linking for stabilizing the cornea, for the intracorneal ring segment for centering the cone, and subsequently the toric intraocular lens implantation 6 to 12 months later for visual rehabilitation of these patients. Just in case the coning is not so extreme, but still it is somewhat decentered, you can see over here, I would like to center this here as Chitra was alluding to earlier. You can do a collagen cross-linkage with the topo-guided PRK, and once this gets, you can see the significant, it's almost a regular bow tie with the rule bow tie that you have here. And you can, most importantly, the best corrected visual acuity from 6.18 has improved to 6.9 plus. So this eye is now ready to be rehabilitated with a phakic intraocular lens. Similarly, you can see over here a more severe degree of refractive error, but the best corrected visual acuity is just 6/12. And I am going to go ahead and with an CXL and an intact procedure. Please understand that the amount of cylinder has gone up from 1.5 to 4 diopters. That doesn't matter to me. The more important aspect is that the cornea has got more regularized, and the best corrected visual acuity has improved from 6.18 to 6.9. Once this has happened, then even this degree of ametropia can be dealt with quite adequately with a phakic intraocular lens. And whenever you're doing keratoconus, there can be chances of lens being oversized. simply because if you are taking only the central AC depth, like in this case, and if you have a central cone, you could get the AC depth as much as 4 millimeters, but there can be peripheral crowding. It has been suggested you can get multiple readings from the periphery also, but then there's no algorithm that's available to size your lenses according to the measurements that are taken peripherally. So what we do is to just go one step or two steps down. In the case of a ICL, it will be one step down because it's 0.5 millimeter steps. And in the case of a IPCL or an ICL lens, it will be two steps down because they come about 0.25 millimeters steps. And when we reduce this by 0.5 millimeters, it seemed to work well. As you can see here, this is a high vault in the two eyes, and as when it comes to an exchange, all I have to do is to bring the lens out like this, and just bring one of the haptics out, and subsequently bring with a hand over hand technique, just get the lens out, and a lens which has been undersized is going in, and that's a fairly routine surgery. You can also use post-corneal transplant.
We have to conclude.
Yeah, especially you have to be cognizant of the fact that that the endothelium, there should not be minimal damage. So use good amount of endothelial protection also, and go ahead and implant these lenses. And low vault and cataract, just because there is low vault, if the anterior capsule is quite clear, then we do not go ahead and do anything about it. I'll skip this video about this cataract surgery post-ICL. So in our quest for an ideal refractive correction, I think phakic IOL is a useful tool, and deep understanding of its limitations and challenges is essential. And for a modern day refractive surgeon, to be a complete refractive surgeon, it's essential to incorporate this in their armamentarium. Thank you so much for your attention.
Thank you, Dr. Ramurthy. As we are running late, we'll skip the questions, and I'll call Dr. Shreyash Ramurthy to talk on optimizing outcomes from SMILE. Maybe just one comment is, in an age-stabilized keratoconus, like the patient is in 30s and the topography is stable, probably, and if he's comfortable with his spectacle vision and does not need contact lenses, these patients we can do phakic IOL without combining it with cross-linking. So on to you, Shreyas.
So I'll be presenting this topic on optimizing outcomes in lenticule extraction, and it is exciting days for lenticule surgery itself, as we now have multiple platforms available. You have the SMILE with the Visumax 800, you have SMILE Pro, the Clear from Z8, Elita from Silk, and AIOS from Schwinn. So with all these platforms available, now it also becomes a question of where results are better, where results are faster. What we really need to know is that energy optimization is probably a key word that is necessary in all of these equipment, and therefore I will be concentrating a little bit on energy optimization in the initial part of the talk, and then add a little bit more about centration and docking, and then finally the dissection techniques, which I feel are the three key variables as far as optimizing results in lenticule extraction surgery. So now with the comparison, when you see that the newer machines have a higher repetition rate or a higher frequency, and at the same time, and because of the higher frequency, are able to deliver a lower energy per pulse. So they are smaller pulses with a shorter duration and lower energy. The idea is this will ensure that the cut is a little smoother, and therefore you may have a slightly better interface, because of which you may have a faster visual recovery, lesser tissue damage, and lesser inflammation. One other thing which needs to be noticed is that while Visumax and to some extent AIOS has a curved interface, the Zima and the Elita have a flat interface, which causes a higher pressure and flattens the cornea, which results in certain folds which develop in the cornea. The patient also loses fixation. With regard to cyclotorsion compensation, it's automatic in the Visumax 800 and the AIOS, whereas in the Elita and Zima and the Visumax 500, it has to be done manually. Again, the centration system is automated in the Visumax 800 and AIOS, whereas there is a little manual component required in both Zima and Elita. So now when we look at the ideal energy setting, now it varies not just by platform, but also the machine-to-machine variation with each within the same platform. Your OT environment, the optimization of energy for that particular environment, the surgeon in terms of your ease of dissection and the time taken for dissection, it's important to spend time on each of these parameters before reach the balance. Because there are multiple parameters which look into how the clinical performance can be affected. And really what we can play around with is really only the pulse energy and perhaps the spot size. Rest, everything else is more or less fixed and for that particular machine that you have. Now, why are we talking about this so much? Because when you have excess power, at least in machines which have a venting incision like the Z8, there is an escape of the excessive OBL. But in other equipment, it's only the incisions when they open up that the OBL will escape. So when you see excessive escape of OBL, you know that higher energy has been delivered. If you have a very opaque picture, which I'll show in subsequent videos, that also indicates that this is possibly excessive energy and you need to bring it down. Or sometimes you might find that the cut is very smooth, that the lenticule comes out very easily. And this is something which we have learnt over time, that not every easy extraction of lenticule equals immediately good visual outcomes on day one. Sometimes you may have excess energy which has led to a very clean cut, very easy removal of the lenticule, but this excess energy has led to tissue damage which makes it a little more difficult. So what you want with an ideal power is minimal gas escape, a very homogeneous cut, and uniform resistance whenever you have. So you want a uniform energy delivery rather than patchy excessive OBL as you see on the right side picture. Now the energy settings can be varied in almost all instruments, all platforms, and generally we keep a lower power for anterior and a slightly higher power for posterior. And essentially this is because the greater the depth that you are at, and if you are having a higher refractive error to correct, then the power is increased a little bit. In all these equipment, we start off with a higher power and then slowly titrate it down, keep lowering and lowering. In the clear platform, we started it at excessive of 50, but now we are down to the low 30s as far as what is optimal for our machine. But that does not mean that just because it is optimized for our machine, that we are going to have the same number which works well on another platform. This is on the Elita again. We started off again in the high 40s in this, but then we found that it was for the glass burn threshold in our machine was quite low, and therefore I had to even get a special pack for reducing the energy below 40, and at around 35, 36, 37 is when we started seeing different results. So again, the power can be managed for anterior to posterior to the side cuts as well as the ring cuts itself. So appearance of the OBL pattern, adequacy of the dissection or the ease of the dissection, and the day one visual recovery. These are the three clear parameters which helps you recognize whether that energy needs to be further lowered or raised a little bit back to what is optimal energy for your particular machine. Apart from that, you can also have some interface and dark spots. So one is the energy delivered by the machine itself, but the energy taken up at the patient's eye level, it can be also determined because of these factors, like you may have some dark spots or interface debris which has led to an inadequate laser delivery, which is now will lead to a difficult dissection and difficult extraction of the lenticule. The ideal preparation, however, would preferably be applying some saline or BSS just before you dock the patient, wiping around the fornices, not have excess fluid as well, but have a uniform tear film or tear meniscus on the anterior epithelium before you go ahead with the dock. The next important parameter becomes centration. Now, while in some of the equipment you have a curved interface, less pressure at the time of dock, and the patient is continuing to fixate, you could use the fixation light as a target for centration. But whereas when you're doing the equipment which have a flatter dock, the patient loses fixation, and because of the higher pressure, the need for centration becomes very important, because you then end up having a position where the pupil is shifted in relation to the corneal apex. It's essentially because the cornea is pressed into folds, and what we perceived as the center of the pupil to begin with is no longer the center of the pupil, and therefore a manual marking also becomes necessary. There are various instruments described for using manual marking, and this is just one of them which we use. And then once the manual marking is done, once you then take the patient, this is useful for both centration as well as for cyclotorsion compensation. You will see on the ASOCT pictures as well, as we dock and we take the patient up, these marks are clearly visible, and then you can rotate the axis and position the lenticule manually according to where your original marks were. And as the ASOCT image becomes live, you see that the amount of folds that is there in the posterior cornea. So this is why the centration becomes extremely important on almost all platforms. Cyclotorsion compensation can also be done accordingly, and this is just on the Elita platform. Again, you can see after the dock, once it's locked, you can see that blue mark here. This is the center which has been marked under the using the Purkinje image on the corneal apex, and you then center it on that particular mark of the lenticule. So now you have the centration which is delivered. Because decentering these lenticules can itself induce coma and have a suboptimal visual recovery. Quickly on the dissection itself, if I have time, I'll take a minute or so. Yeah. So if you have higher energy, as you can see, this is a completely unedited video. You will notice that the dissection is easy, and you are able to remove the lenticule very easily. So I usually use this, go into the side pocket and come anterior, which makes it very easy. You always seldom have a difficulty. Now you'll see as the spatula goes in, there's hardly any resistance, and it almost seems like the surgery is ideal, that the entire surgery will be over in less than 40 seconds. Now, while the ease of dissection may appear very easy, this patient did not have a good recovery. I in fact went back to the surgery to see what I did wrong, and that's how I took up this for recording. This patient had only a 612 vision on day 1. This is essentially because excessive energy was delivered onto the cornea, and this has significantly improved after optimizing energy outcomes. Whereas if you see a patient with a more uniform OBL, you will see that while doing the dissection, there is a little bit more moderate resistance, as you can see in this patient, and the lenticule doesn't come out as easily. But this patient had a 6.6 vision on day 1 recovery. So pretty much 2 laser deliveries on the same platform, but where there is a difference in the outcome is essentially because of the amount of energy delivered even in the same surgeon's hands. In case of excessive OBL, in this case, what really helps is the wedge technique, where essentially you, when you're doing the posterior dissection, you leave behind a small part uncut, complete one side, and then complete the last aspect, so that you continue to have some counter traction and the lenticule does not roll up. This is just, I'll quickly close with this. This is a technique where you can use with the lenticulorhexis or the lenticuloschisis, where essentially we are trying to reduce the amount of manipulation in the tissue. It's not that the time taken itself is saved. So essentially you go along like a rhexis, complete one side, curve to the other side, and then take this around like like you would do for a capsulorhexis, and then complete it and bring it out. The time taken itself may be very similar. It's not really about saving time, but it's the fact that you're distorting the ends a little less, and this may possibly potentially result in less Bowman folds, which itself could have a slightly faster visual recovery, or it could be equivocal. Again, if it is a non-uniform OBL, it may be a little more challenging to do this technique, and you may have to grasp and re-grasp at different levels to avoid tearing the lenticule. It's very important that you ensure that it is done carefully and appropriately, so that if you can always resort back to the normal technique in case this is difficult. But in some of these cases with a very tighter where the OBL has not been very uniform, you may have this difficulty where you have to grasp and re-grasp again and closer to the tearing edge, like you would do with a rhexis which is tending to run off, and then complete the surgery. But then it can be done even in these cases with excessive OBL. But suffice to say that the visual recovery, even with the lenticulorhexis, could be a little lesser if the energy is not optimized. Again, you can use retroillumination to identify any retained lenticules. You could use IVTA for staining. And really, what I would like to conclude with the message is titrating the power with optimal dissection techniques can help in faster visual recovery. Thank you so much.
Thank you so much, Shreyas. I was so specific that optimizing outcomes in SMILE should be dealt in such a way that you take out those salient, difficult issues which is there in all our minds and sort it out. And you did a very great job of it. We go on to our next speaker, Dr. Mahipal Sachdev, who needs no introduction, a very eminent refractive surgeon. And he's going to tell us about some of the testing times with femtolasic. He'll be followed by Dr. Kumar, and I would request all of you all to make your talks as less than 8 minutes. And it's very sorry we are running late. And after Mahipal, Dr. Kumar would give some complex case scenarios. And then we would have our guest speaker, Dr. Mohammad Shafiq, who will be talking on customized surgery for refractive and therapeutic corrections.
Mahipal, you got 8 minutes, I got 6 minutes.
I'll take 4.
We'll take 4?
No, don't take 4. Our audience want keep it 8.
Anyway, good afternoon, everyone. Thank you for having me. I'm being transported back in time because I don't do very less of LASIK now, but let's talk about flap complications. So the complications of LASIK, as you know, can be grouped into refractive, laser, and flap related. So I'll be talking mainly about the flap related complications. One of the complications that you see more often or you would see with LASIK is, as compared to SMILE, is a DLK. So this is you have to differentiate it from a central toxicity, or this is a diffuse inflammation comes as a sands of Sahara. The immediate thing in this particular thing is to, if it is of a higher grade, is to wash it and to clean the interface and maybe do a little bit of antibiotic and steroids at that particular time. And just the washing at times and high doses of steroids, which is topical and systemic at times with vitamin C, is what is required. Second is epithelial ingrowth. This is the epithelial cells which keep going in. Normally there is a track that can be seen. These are epithelial nests which are there. Re-lifted flaps always give rise to more chances of epithelial ingrowth rather than a fresh cut. You don't see this in a lenticular based surgery, but this incidence with the femtolasic that you have and the flap, rather than being a beveled, the cut being, instead of a beveled, it being at about 90 degrees or otherwise, the incidence of epithelial ingrowth has gone down. AIOS2025, as you can see, is a good tool by which you can make out as to the extent of the epithelial ingrowth. These are 2 epithelial ingrowths. This is, I don't know, maybe 10, 15 years old. And this is this is not that old. So you can see there is epithelial ingrowth here. The key here is to treat early. This one came from some other center, not ours. And this is the track, as you can see here. The identification of the LASIK flap is important. You just lift up the LASIK flap. The important thing is to try to remove maximum amount of the epithelium which is there. So you can see here, this was the epithelial ingrowth which is being scraped. So scraping is one important thing. You can stain it with the fluorescein stain to see as to where it is. As you can see here, we are lifting it here in this particular case. Wherever there is epithelial ingrowth for a long time, you could have a stromal melt. So you have to be careful at that. Here you can see we are under surface of the flap also. The residual epithelial nest need to be taken out. You can see this is liquefied epithelial nest which are here. Backside of the epithelium, washing it very well. And then there are 2 things that you can do. You apply mitomycin C, or you can apply absolute alcohol. It has also been shown that you can blow up the nest with YAG capsulotomy, but not capsulotomy, YAG laser. Then what we do is, after we have cleaned it up, we put glue, as you can see, glue. And once you put the glue, then you have to seal it up. You can see this is pretty edematous. We have removed from here. And I would always put a glue and a bandage contact lens. In case there is significant melt under those circumstances, you can also put a suture. So this is the same patient that you had, the earlier thick one. And this is 10 years hence. You can see that I still remember, she's a school teacher from Delhi Public School, and she had a bad time and we removed it, it was fine. One more thing that can happen is regression or ectasia. The 2 things have to be differentiated. In regression, you will have to see that there is no changes of irregularity in the topography, and the incidence of LASIK enhancement is about 5% in literature. For the lenticule, it is slightly lower, which is there, and depends on the optic zone, depends on certain factors which are unknown. It depends on the thickness of the cornea, etc., which is there. When you want to do an enhancement, you have to wait 3 months and maybe 3 to 6 months. Regular tomography with stable refraction is important. The AIOS-OCT is something which is a good tool where you can make out the flap thickness. At the end of the day, you have to know what is the residual bed thickness that is there, how much correction you have to do, and how much would be the residual bed thickness after the correction. If the flaps are very thick, like we had earlier with the Hansotome, you can do a surface ablation in these cases. While if you have adequate tissue, so you look at the flap thickness, you look at the epithelial thickness, you look at the completeness of the flap on the AIOS-OCT and calculate what is the RST, that is the residual bed thickness that is there. We can easily do a flap lift. People say you can mark with a 30 gauge needle on a slit lamp and then take a blunt spatula, and you can identify the where you need to go. But I have never used a needle, etc. All that you need to do for doing a flap lift is just use a sponge, dry it up, just press this. Can you see this? When you press this, this will come into play and enter the plane which is there. I have lifted flaps almost 15 years, 17 years post the thing. You can always, because this cleavage plane always remain. The only thing is that you can have an increased incidence of epithelial ingrowth, so you can relift and do this. And just be sure, wait a little longer for the flap to come back and sit back. Recut with a keratome on another flap, you can get lamellar slivers. If you get these slivers, we tend to throw them off. If you throw them off, you will get irregular astigmatism. So please do not throw. If you have to look at the chances of double cut. It is always better to know as to what it was, and you can go thicker and bigger. So that is what you can. But in case of a femto-LASIK, you go smaller. So if you have a femto-LASIK flap, you know the size of the flap, then you can reduce it and do just a fresh side cut, and you can relift that. So that is what needs to be done. In case there is post-LASIK ectasia, various factors which are there for ectasia, just to tell you, a corneal cross-linking alone in a post-LASIK cornea or a post-refractive surgery cornea will not work, because these are two dissimilar zones that you are trying to cross-link. You have to put in, I have no personal experience about CARES, but you need to put in a segment, and I normally do an intax along with the corneal cross-linking or the same sitting. See, some people say you do a cross-linking, see whether it works or not, and then think of an intax. That is intuitively wrong. If you have something, you have a building which is tilting, you first put cement, you have frozen it there to whatever extent, and then you try to straighten it, it's not going to work. So you have to try to straighten it with the ring and at the same time put cement. So that is the thing. It has to be immediately one after the other on the same procedure day. This is the ring that I make with the interlace, you can see, and then go in with the clover leaf. Go in intuitively into the depth. You have to go perpendicular and then go in. Take the ring, which you can see, sorry, I just fast forwarded. You can see the ring, go perpendicularly and then thread it. You have to calculate 1 ring, 2 rings, what is the size of the ring, the thickness of the ring, and the arc segment. These are 2 rings. Put a girdle suture so that works as an artificial limbus, and then scrape up the epithelium and do the corneal cross-linking for them, and it works fantastically well. We have, this is a comparison which is there. I think it is the last one. This is a flap stria. Whenever you have a flap stria which is there for a long time, if it is on the next day or something, you can just pick it up and read this thing. But retroillumination, dilated pupil on a surgical microscope, clear thing is you have to remove the epithelium in long-standing flap stria. You can see the quantum of stria. They were never coming into play as such. After you have done, because the point is that the stria get anchored with the epithelium and they will remain there. So you have to then put distilled water to make the whole thing edematous. And once you have that, you will use to iron these This is distilled water that is being put. You iron these, use these sponges, one side, other side. They stria never disappear on the table. Be very careful. You'll keep on feeling that why are they not going? They will at best become slightly less. But once you have done this, done the proper massage, put it, maybe used a little bit of a hot spatula and put bandage contact lens, the next day this is what you're going to get in the next few days. This is what you have, and the patient recovered good visual acuity. So friends, I think this is couple of the complications, how to manage them. And challenges are what make life interesting, and overcoming them is meaningful, I think. But we have moved on from the flap to either a surface ablation, to some cases to large number, and to the lenticular extraction. But those who are doing flaps, the chances of having these type of complications are there, but you can, with proper knowledge and skill, you can manage these complications. Thank you very much for your kind attention.
Thank you very much, Dr. Maipal, for a very detailed talk. We will have Dr. Kumar, doctor from Mumbai, who is again a very veteran cataract refractive surgeon of long standing, and he's going to be talking to us on something new and interesting. While you start off? Okay. There are one or two questions, time permitting, we can discuss. New marker for lenticule surgery. On to you, Kumar.
At the onset, thank you, Chitra, for this opportunity. I'm going to go Zoom because we are running late. I've been doing bladeless LASIK since 2013, so it's not that I've started yesterday. Now you can see that I have a decentered femto flap. So if you can see, surprisingly, the hinge is here, exactly at the pupil, and I've also managed to do a little bit of femto energy on the conjunctiva. So this happened in 2018, and this you must understand that you know your technology, and this was one of the initial mistakes that I've made. So I'll explain to you why that happened. As I mentioned, I'm doing that since 2018, 13, now coming to this. So as far as we do bladeless flaps, the bladeless LASIK flap can be decentered, but we don't need to worry because our excimer treatment is on the pupil. So that is completely fine. So you can have a slightly bladeless LASIK flap which is nasal but not temporal, and the patients will still do well. And we know that when we do LASIK, the pressure of the eye goes up and the pupil dilates in different directions. So now the applanation area that you can see in bladeless LASIK on the Zimmer system is the entire limbus. So you can see the limbus, you can see how the flap is going to be created, and everything is quite visible. But when it comes to lenticular surgery, it's quite different. So on the Z8, I can do cataract, LASIK flaps, lenticular surgery, intacs, and corneal applications. But when it comes to lenticular surgery, you can notice that the limbus is not visible. So the pupil is visible very well centrally, and it's perfectly centered, you can see that, and it automatically aligns till 15 degrees in the lenticular system as far as the Z8 is concerned. So you can see that we can't see the limbus, that is part one, because of the camera angle in the system. So the camera angle in clear is different from the camera angle as far as bladeless LASIK is concerned in the Z8. So here you can see that the applanation area appears smaller, so you can't see the limbus, but actually the whole area till the limbus is getting applanated. When the pressure of the eye goes up, the pupil dilates in different directions, and so if you try to do a pupil-centric treatment, it may not be the perfect way to go around. So I believe that the best thing to do is to mark, okay? So lenticular surgery, the centration is extremely crucial. And so understanding the technology is very important. So the camera angle inside the system is different when it sees in different steps of the procedure. So you can see this, actually it's an optical illusion. This is how the photograph is actually taken, and the camera angle is most important. So Shady Awad's marker was used is used quite commonly. I further modified it, okay? So here you can see as far as the lenticular extraction is concerned, it has to be perfectly centered. So this is the marker that we have created. It is almost similar to the marker that Dr. Ramamurthy showed you. But I have removed the center part and made the extension longer. And what I do is I use the Virion technology for marking. So I take the patient to Virion, mark there, and this can never go wrong. So mark in spherical errors and mark in spherical cylinder errors. I personally believe that not marking in spherical errors may also be a mistake, and that may also give not perfect results. Once I have marked, I put a drop of dye because that will get your mark more accentuated. And then we apply the applanation as far as the Z8 is concerned. In Z8, the marking automatically aligns till 15 degrees, so you don't have to worry about alignment. So that is one big advantage as far as the Z8 is concerned. So you can see this is how it goes. And once it automatically aligns, we don't need to worry as far as the centration is concerned. And now you can see I still make two cuts. I don't do a single cut. The right one goes anterior and the left one goes posterior. So I'm not going to struggle with which plane I'm in, etc. And that makes the life much more easier. Just go with one side, and that's the Rhine-Einstein dissector, and the left side goes posterior. Go ahead, hold the lenticule and get it out. So according to me, marking is very, very crucial. So you can see that I've marked it perfectly, and this can never ever go, and comes quite to the center. The award marker marks only till here, and that's why sometimes it was a struggle. And here you can see that it automatically aligned. I didn't need to do anything to align the marking, and that's one big advantage. And let's see one more video. You can see the marking, okay? So now we build up the pressure, the pupil slightly dilates. Once the pupil slightly dilates, you dock on the handpiece. Once the handpiece is docked, now we go ahead and make the alignment. Now you'll see that it automatically rotates. You can manually also rotate it. That's another big advantage, that you are just aligning the axis and manually rotating it and making sure that it aligns perfectly. So post-operative images is extremely well centered. You can see these are post-op images of clear or a lenticule procedure, and very well centered, and there is never a problem. So the outcomes depends on pachymetry, laser energy, of course, as rightly showed. Look for the gas bubbles, stromal fiber arrangement, Corvus if necessary, lenticle centration, according to me, it's important. Shape of the cornea, of course, the surgical area, etc. And if you don't understand more, I always say ask Rohit Shetty. Thank you very much.
Thank you very much, Dr. Kumar. That was an interesting talk. I'm glad you insisted on talking that. So we now go on to our guest speaker's keynote address. He is none other than Professor Mohammad Shafiq, who is a professor of ophthalmology from University of Alexandria, Egypt. And he's going to talk to us about customized surgery for refractive and therapeutic corrections. On to you. Sorry for keeping you waiting, doctor.
No, don't worry. Thank you very much, Dr. Chitra Ramamurthy, for the introduction. Thank you for the esteemed panel. I'm really glad to be with you today. And I'm going to address a line time analysis of my practice during the past 30 years. I'm practicing refractive surgery maybe since 1991, when the time was a radial keratotomy. And now I'm going to shift my customization to another level. But let me start with the customization. This is my financial disclosure. And the story, why do we really need a custom-made refractive surgery? Actually, because of three major causes that we are going to address in every patient. Number one size doesn't fit all. And number two, targeting the supervision. And of course, number three is addressing the irregular cornea. And 25 years ago, when we got introduced to the science of aberrometer, we got to understand that one size doesn't fit all. These are three patients for the same refractive error. Nevertheless, they are totally optically different. This was the classical teaching that we got to know from the perfectionizing the aberrometry. And because of that, if, for example, you have a reading from your aberrometer like -188 cylinder, and this happens every day, while the patient is a manifest refraction of only -1.5 cylinder, you know that the rest of the cylinder is in the higher order aberration. And we know by a mathematical equation, which is a little bit complicated, that the astigmatism goes higher with a higher order aberration and the pupil size. So one size doesn't fit all, and if you really wanted to have a happy patient, you have to customize his refractive surgery. More than 12 years ago, we published the first publication on the use of the customized refractive surgery with front guided type. on the virgin corneas, and the wow effect was there. 26% of the patients were seeing 2016 or better. So if you want to advise or to promise your patient a kind of supervision and extend the vision beyond the human ability that we know, you should go for a sort of customization. We knew since back then from this nice work of Shalita that if again you want to have a patient with a hassle-free halos, glare, night vision problems, and the secondary imaging ghosting, you have to customize the vision, or you have to customize the refractive error to do to have a happy patient and to avoid all this hassle fuss. And thirdly, the most important thing that we're going to address now is a kind of irregular cornea, which is a challenge that we meet every day as a refractive surgeon. You might say that irregular corneas are very rare. No, oppositely the contrary, because every mixed astigmatism, every hyperopia, every high astigmatism is a kind of irregular cornea. Every previously touched cornea with a previous LASIK or even SMILE or PRK is an irregular cornea. Every subtle opacity on the cornea is an irregular cornea. So if you have a refractive practice, you might have half of your patients with a kind of irregular cornea that you have to customize the ablation profile with it. We began with the topo-guided ablation profile, and Dr. Shitara Ramamurthy addressed nicely every single profile that we had, and I started the topo-guided ablation profile and then followed by many other platforms, and that was a kind of a customized one in the year 2004. And of course, it ended with the nice and well-known Athens protocol addressed by our dear colleague John Kanalopoulos that changed the world back then in treating the irregular cornea, and on top of which is the keratoconus. And for me, the topo-guided ablation profile is so harsh. It's like killing an ant with a sledgehammer. While you wanted to flatten the whole cornea and regularize the whole cornea, you might have a nice pencil. And this was addressed by my dear colleague Gustavo Tamayo when he said back then that it is a kind of a kind of crude cause-effect relationship. 2007, the nice tool of the corneal wavefront invented by Schwind again was addressing this kind of ablation profile by simply deducting the wavefront from the normal placido disc, and I used this to have a significant treatment of the significant decentration of hyperopic patients, some kinds of very hard irregular corneas. Yet, for me, if you treat only the anterior surface of the cornea, you are uncovering the posterior surface of the cornea, and this might have a bigger problem and might unreveal the irregular surface. For me, a wavefront-guided ablation is a proper addressing of this, and of course the introduction of the higher definition aberrometers in the year 2012 or 2012 was really the treatment of a choice, and I addressed this by the first publication of using the higher definition aberrometer to address the irregular cornea, with nice examples like those with an irregular cornea, where you create an irregular ablation profile, you go and do it by removing the epithelium. A wavefront guided ablation was the perfect choice to regularize the cornea and to provide the patients with a very good vision. And these were the corneal cross-linking patients, and I changed totally the paradigm. It was a paradigm shift. You have a nice point spread function at the end, and it was my publication in 2016 by shifting the wavefront guided ablation and treating the keratoconus to do it after 1 year of cross-linking and to address properly the irregular cornea. You have hundreds of bilateral keratoconic patients. When you create a nice shape with a wavefront guided ablation profile, and you target more or less the emmetropia for those patients. Finally, the legacy of the refractive surgeons that we all taught is coming from printing a lens by the data that we get from either a tomographer or an aberrometer, something which we have to change because aberrometers are still short because of cross-over effects, and we know this very well. they lost a lot of information in a small pupil, and again, the polynomial grading interdependence that again makes a big fault with the aberrometers, and the aberrometers are not so fantastic. Now it is time for the technology to change, a major change, which is the ray tracing principle in customizing our refractive surgery. We know by fact that the ray tracers are much better aberrometers in tracing the rays to the fovea. Nevertheless, no technology up till now had able to do a ray tracing guided ablation. You have to take into consideration that ray tracer, yeah, just a few minutes and I will finish, takes into consideration the epithelial lens, which really does a big thing or a chromatic effect in the irregular cornea. Again, it takes into the consideration the posterior surface, which is mitigating the anterior surface that changes. So if you take the summation of all of them, this will make the ideal shape. And this is the new thing that we're targeting. The ideal shape is to create an ideal shape that is totally fully customized regarding the optical zone and even the connecting zone to retilt the cornea and to customize properly the ablation profile. Like exactly the genius of Michelangelo, who imagined the ideal shape out of a block of marble, we imagine the ideal shape out of the irregular cornea, and we do our surface ablation tailored to the ideal pupil. And these things, the ideal pupil, can of course, make a kind of ablation profile very small. And this is a total change or a paradigm shift in our thinking. You can do an optical zone of 2 or 3 millimeter because we have learned from the Stills-Crovert effect that the most important 2 or 3 millimeter, the most important zone for our vision is the 2 or 3 millimeter that reflects 80% of the vision. These all are taken by two intelligent machines. The Precision, which is a high resolution tomographer that will convert into the ray tracing into a true ablation profile, and the P-metric, which will calculate the ideal pupil for the technology. Even that, all things go to the cloud, and you can do your surgery remotely. And a couple of months ago, I did or performed the first patient from India, and the patient was sitting on the table in Italy, which is again will have its future application. Our dear friend Cosimo Mazzotta published the first ray tracing guided ablation, a transepithelial one for treating the keratoconus with marvelous results, and the future is now. I invite you all to these three important meetings which will take place, taking place in the WKC, which is the World Keratoconus Congress in Athens, the Lenticule and the DDEOS, which will be in India next year. And this is just a nice picture for a limestone for a man who died 2,500 years ago in Egypt, and the transliteration on his tomb limestone that he was Ni'an Khidwaw. Maybe he was the first ophthalmologist. He was the ophthalmologist of the king like 4,500 years ago. And I thank you very much again for listening.
Thank you very much, Dr. Mohammed, for bringing in new thoughts for refractive surgery. Thank you very much. Thank you one and all for being so, sitting patiently and hearing all of this. We'll definitely try to come back next year with something even more relevant for you, so that which is you come and sit for.
Dr. Mohammed, I have one question for you, just one question. We all talk about supervision, supernatural vision, 20 by 5, 20 by 6, or whatever. Doesn't it disturb the mind when you see too much?
Actually, the too much is 2010. Maybe yes, but 2016 is not that supervision, but it would be a supervision for those who had 20/20 before best corrected visual acuity. Good question.